Good afternoon, and welcome to the Washington University School of Medicine's annual Dr. Martin Luther King Jr. Lecture. I am Dr. Will Ross, Associate Dean for Diversity and Professor of Medicine at the University and the School of Medicine. I welcome you on behalf of Dean David Perlmutter, as well as Chancellor Andrew Martin, along with the administrative team in our Office of Diversity, Equity, and Inclusion, and our Office of Diversity Programs. Well, it's been quite an eventful and tragic series of events in our country over the past week. After assault on our capital by white supremacists and right-wing extremists, I, along with most of you, have lost a lot of sleep reflecting on how this country, guided by a universally embraced moral compass, can emerge stronger and committed to the core principles of equity and inclusion. I remain optimistic and I hold a whole lot of hope for a better America. That hope is based on an assertion of moral leadership from venerated institutions like ours and from grassroots and civic leaders like those who are participating in this webinar. With that in mind, we wanted to make this Dr. King lecture even more reflective and impactful. We hope, and I dare say we will succeed because of the quality of the speaker we've engaged, to have a deeper reflection on the state of Black America by probing the intersection of critical race theory, the COVID pandemic and racial disparities it unmasked, and opportunities for social justice in the new administration. After researching potential speakers, we really have been fortunate to land on one of the most astute thinkers in this area, Professor Dorothy Roberts. You'll hear an introduction of Dr. Roberts shortly, and you will be, of course, impressed by what she has to say. We will be inspired, and I know we'll be moved to action. I now want to introduce the Chancellor of Washington University, Andrew Martin. Andrew Martin was appointed our 15th Chancellor on July 14th, 2018. From 2014 to 2018, Andrew Martin served as the Dean of the College of Literature, Science, and Arts at the University of Michigan. Previously, he had served in various positions here at Washington University in St. Louis, including as a Charles Nagel Chair of Constitutional Law and Political Science at the School of Law, Vice Dean of the School of Law, founding Director of the Center for Empirical Research in the Law, and Chair of the Department of Political Science and Arts and Sciences. In his time here, Chancellor Martin has challenged us, Washington University community, to be more visible, to be active members of the St. Louis community. He has asked that we become Washington University in St. Louis and Washington University for St. Louis. We have acted on that vision, that charge, and I think that we become better people, a better university, and a better community as a consequence. Following Chancellor Martin's comments, Chancellor Martin will introduce Dean Cherie Wilson. Cherie Wilson is Associate Vice Chancellor for Diversity, Equity, and Inclusion. She has been with us over the past 2 years and also has been just a monumental source of change and inspiration for all of us, moving forth with a strategic plan for diversity, inclusion, and equity at the School of Medicine. After Cherie Wilson introduces our speaker, we will follow up that presentation with an opening for you, the community, to call in and engage. That engagement will be moderated by Adrian Davis, who serves as our Vice Provost and the William N. Van Cleve Professor of Law. We're really proud that Adrian Davis has also accepted the role recently as Director of the University Center for the Study of Race, Equity, and Ethnicity, and she is the founding and co-director of the Law and Culture Initiative. So I now introduce Chancellor Andrew Martin.
Well, thank you very much, Dr. Ross. Good afternoon, and thank you once again for joining us for the Medical School's annual MLK Celebration Lecture here at Washington University in St. Louis. A word of thanks to those who helped prepare this afternoon's event, as well as to our speakers. Professor Roberts, I look forward to hearing your wisdom as we reflect on the two pandemics in which we find ourselves. If I may, I'd also like to offer a short reflection. As I think about this past year, It seems that the words, "I can't breathe," aptly summarize the world in which we've been living, and in fact, the circumstances in which people of color have been living for centuries. I can't breathe. The devastating last words uttered by George Floyd as he was mercilessly killed by a police officer this past June. I can't breathe. Words also uttered in hospital beds around the world as a global health pandemic has taken hold of our most vulnerable populations, including and especially underrepresented minorities who have been impacted at alarmingly higher rates. I can't breathe. Perhaps words spoken internally by those people who lost their lives during January 6th horrific terrorist attack by an angry mob at our nation's capital. While the pandemic and the ongoing racial violence against people of color and Black people in particular has shone a bright light on racial injustice, the events that took place that day only shone an even brighter light on the reality that we live in two Americas. While millions of people have lost their ability to breathe, as a nation it feels we too are suffocating. As I watch the news with horror and outrage, and as I reflected on what I was going to say today, the only thing that is repeated in my head over and over again is this is not the nation Dr. King dreamt about. No, in fact, to many of us, it doesn't feel like a dream at all. I can't help but think about what Dr. King would say if he were living today. What would he think? How would he feel? Anger, sadness, and disappointment, most likely. Perhaps even feelings of defeat. That said, I believe that Dr. King wouldn't sit in his disappointment for too long. Instead, I believe he would remain hopeful that justice would eventually prevail, and he would use it to strengthen his resolve to do what is right in the face of such egregiousness. In fact, Dr. King once said, "I believe that unarmed truth and unconditional love will have the final word in reality. This is why right, temporarily defeated, is stronger than evil triumphant." While the state of our world feels downright devastating at this very moment, I hope we can remember Dr. King's words today as we commemorate his life and his work. May we also remember them tomorrow as we begin anew the extraordinary work that lies ahead, the work of assuring all people, including and especially people of color, are made to feel safe, secure, welcome, and included, and that they have the same opportunities to thrive and flourish. Let us also remember these words as we consider the ways in which we have made progress here at Washington University in the nearly 60 years since Dr. King first shared his dream. On a singular level, I am reminded of this through the work that you do each and every single day as colleagues in the School of Medicine. This past year especially, you have worked tirelessly to ensure that as many people as possible have the chance to breathe. You've done so through compassionate patient care, through research that uncovers disparity and inequity, through educating future healthcare leaders with an innovative curriculum, through your advocacy, and much more. Please know how extraordinarily grateful I am for the sacrifices you have made and for your continued passion to both save and change lives. While we still have work to do, I remain hopeful that the arc will continue to bend, and I remain confident that here in this community, we will continue to engender change and use our education, research, and patient care mission to address racial disparities and inequities in order to make the world a better place for all people to live. Thank you again for being here to commemorate and celebrate the life and work of Dr. King. Now I'd like to turn things over to Associate Vice Chancellor and Associate Dean of Diversity, Equity, and Inclusion, Cherie Wilson, to introduce our speaker. Cherie.
Thank you, Chancellor Martin, and thank you for always supporting the programming that we do in the School of Medicine. We really appreciate you being here with us today. I first want to begin by thanking all of the committee members who have put together an extraordinary panel of events that will be occurring throughout the week as we celebrate Dr. Martin Luther King's birthday and life. And our theme this year is Good Trouble in honor of the late John Lewis. So keep that in mind. Check our website for additional programming that will be happening. Chancellor Martin and Dr. Ross have outlined extraordinary comments regarding how probably many of us were feeling last week. And admittedly, for me, and in talking with our team, we talked about this sense of we don't know what else to say. What else is there for us to do? We feel like we keep making statements because we keep seeing things happening. But I also have to say it has strengthened our resolve to continue the work that we are doing, particularly around understanding systemic racism. This is work that we actually began last summer. We continue to do it throughout the School of Medicine. And again, this has strengthened our resolve to continue that work. I have the pleasure of introducing our keynote speaker for today. And she is Dorothy Roberts, and she is the 14th Penn Integrates Knowledge Professor and George A. Weiss University Professor of Law and Sociology at the University of Pennsylvania, where she has joint appointments in the departments of Africana Studies and Sociology and the Law School. She is the inaugural Raymond Pace and Sadie Tanner Mossell Alexander Professor of Civil Rights. Professor Roberts is also the founding director of the Penn program on race, science, and society. She is an internationally recognized scholar, public intellectual, and social justice advocate, and a prolific author. She has written extensively on race, gender, and class inequities at U.S. institutions, and has been a leader in transforming public thinking and policy on reproductive freedom, child welfare, and bioethics. She has authored a number of books, including Killing the Black Body, Race, Reproduction, and the Meaning of Liberty. She has also appeared on MSNBC most recently to discuss the ways in which Black healthcare workers are working to build trust among Black patients, particularly as it relates to COVID and the vaccine. Professor Roberts' research has been supported by fellowships from the American Council of Learned Societies, the National Science Foundation, the Robert Wood Johnson Foundation, the Broker Foundation, Harvard University Program in Ethics and the Professions, Stanford Center for Comparative Studies in Race and Ethnicity, Northwestern Institute for Policy Research, and the Fulbright Program. She also serves on a number of boards of directors of various societies, and again, in recognition of her social justice work, many of those relate to children and her belief in those particular areas. Her recent work also includes election as a College of Physicians of Philadelphia Fellow, election to the National Academy of Medicine, and the Society of Family Planning Lifetime Achievement Award. She has a TED Talk that actually came out in 2015, but still continues to yield a number of views. It has had over 1 million views, and that TED Talk is titled The Problem with Race-Based Medicine. Today, Professor Roberts will be sharing her keynote address, which is entitled Dr. King's Message on Race, Science, and Justice. So I'm happy to turn it over to Professor Roberts. Welcome.
Thank you so much, Dean Wilson. I really appreciate your introduction. Thank you also to Dr. Ross, to Chancellor Martin. I appreciate the invitation and everything you did to organize this, and special thanks also to Liz Riggs for her help. I'm truly, truly honored and thrilled to be able to give this lecture today in celebration of Dr. Martin Luther King Jr. So I am going to share my screen and put up my slides for the lecture. Okay, and I'm relying on someone to shout out if I did something wrong. I'm going to assume everything is fine. So I decided to speak on a message that not that many people have heard of from Dr. King, and that's his words on science and justice. As others have said, we are living right now through very tumultuous times. The COVID pandemic is still ravaging our nation and the world. Just in the United States, there are thousands upon thousands of deaths every single day, and Black people are disproportionately hit by both infection and deaths from the pandemic. Over the summer, we had uprisings in the United States and around the world against police violence and for Black lives, unprecedented in the history of the United States. And then, as Chancellor Martin mentioned, just on January 6th, there was an insurrection that stormed the US Capitol, desecrating it with racist symbols and with people intent on committing murder and kidnapping and mayhem and destroying democracy. So it's pretty daunting to address you in the midst of all of this, and also to relate it to the School of Medicine in particular. And so I thought I would speak about Dr. King's message on science and justice because it speaks to all of these issues in, as Dr. King's words always do, they ring so true today. They bring a message we need to hear even today. Now, in 1963, Martin Luther King Jr. put together a volume of his sermons, which he called Strength to Love. And a number of the sermons speak about the relationship between religion and science. And he made the point that religion and science were not rivals, they were complementary. One of the aspects of his sermons that stands out for me is the way in which he doesn't treat science as opposing religion, but he also doesn't treat it as the truth. He tests both religion and science by looking at whether they promote justice or whether they're counter to justice, whether they challenge the inequities that have long existed in America, or whether they move us toward a more just America. And he wrote in one of the sermons in Strength to Love that men had conveniently twisted the insights of religion, science, and philosophy to give sanction to the doctrine of white supremacy. This idea was embedded in every textbook and preached in practically every pulpit and became a structured part of the culture. And men that embraced the philosophy, not as the rationalization of a lie, but as the expression of a final truth. And so not only religion, but also science, and in a way they were joined together, which I'll talk about some more, to support the idea of white supremacy. And because both religion and science are seen as a truth, manipulating them becomes a way that people can embrace them not as an excuse for the lie of white supremacy, but as evidence that white supremacy is the truth. Now, we see these kinds of twisting of the truth by science continuing today. So when it became clear early on that COVID-19 had a devastating impact on African Americans, with Black people both getting COVID and dying from COVID, in some places at 3 times the rate of white Americans, of course, scientists thought about, well, what is the reason for this? And as always happens when we see health inequities, there is a debate in the hypotheses about the causes. And some scientists immediately jump to what they often do, which is there's something innately wrong about Black people that causes us to have bad outcomes, including health outcomes. This is one of the lies that Dr. King was talking about, the use of science to support a white supremacist idea of innate inferiority. And so some people jump to the hypothesis that there was some unknown or unmeasured genetic or biological factor that was causing these disparities. Others said, no, we can look at structural racism and social determinants of health to explain why we would see these stark inequities in health. And I thought that Kamara Jones, a former president of the American Public Health Association, gave a great interview in Scientific America where she pointed out the mechanisms by which structural racism could produce these disparities in deaths from COVID between Black people and white people in America. She pointed to two mechanisms. One, that people of color are more infected because we're more exposed and less protected. We are more likely to work in frontline jobs, giving care to the elderly and others who are particularly vulnerable to COVID without adequate protections. And she explained that the reason why Black people are more likely to have these low-wage frontline jobs that are not protected is because of structural racism, because of residential and educational segregation, because of limited employment opportunities and discrimination in the job market. And then the second mechanism she pointed to was that once infected, Black people are more likely to die because Black people already carry a greater burden of chronic diseases that make us more vulnerable to death from an infection like a virus like COVID-19. And that too is because of structural factors like living in disinvested, segregated communities that have poorer food options, more likely to be exposed to toxins in the air and the water, and to have less access to high quality health care. I want to point out another mechanism that was suggested by an article in ProPublica. And this reporter looked at, or a couple of reporters there, looked at something that was going on in New Orleans, and that was hospitals telling Black patients that there was nothing more they could do for them and sending them home or to facilities to die, even though their relatives were begging them to keep trying. And this suggests that there may be, as has been found already in other situations, bias either in the minds of healthcare professionals or in algorithms that they use to determine who gets to continue to get life-saving treatment and who gets sent home. And it's possible that this is another reason that Black patients are disadvantaged by these kinds of either individual or structural biases in who gets the best healthcare once they are at the hospital. So Dr. King looked back at slavery to give an example of how science and religion were used to support the lie of white supremacy. He pointed out that people convinced themselves that a system that was so economically profitable as slavery must be morally justifiable, and so came up with justifications for it. He wrote in Strength to Love that science was commandeered to prove the biological inferiority of the Negro. And let me say some more about this. I think that this is, as I've already suggested, one of the most devious and harmful myths that science has created, that human beings are naturally divided into races that are biologically distinct from each other, and that Black people in particular are biologically inferior. Now, how does that become a justification, a moral justification for slavery? Well, we can look to the very invention of race as a moral justification for slavery. Scientists in the Enlightenment era had to come up with a reason why Europeans could enslave African people at the same time that they were promoting a philosophy of tolerance and reason and equality. We could see those ideas being promoted in the United States as part of the rationale for creating a new nation that was independent from Great Britain. And historians have now shown that what Enlightenment scientists did was take a theological idea that God created the races. That was an idea that had already been used by theologians and people in the church to justify enslaving human beings even after they converted to Christianity. And this theological falsehood that God divided human beings into races was then used to justify excluding African people from the religious norms that would prohibit enslaving a Christian. Enlightenment scientists at the end of the 1600s, in the early 1700s, like Johann Blumenbach, adopted really wholesale this idea that God created the races simply by saying, replacing God with nature, saying nature created the races. And they put the races into a hierarchy that they also said nature created, with Europeans at the top and Africans at the bottom, and different other classifications like Americans or Native Americans, Malays or Chinese or Asian, we now would say Asian, in between. But the classifications we use today are basically the same ones that Blumenbach and Cuvier and others came up with in the 1700s. And this was then the rationale that Enlightenment scientists could use, claiming they had moved away from religion, but actually adopting this false theological belief into modern science. And we still see this idea dominating science today. And that's why I say it's not just the scientific invention of race, but science itself was invented, modern science invented with this falsehood of racial classification and biological distinctions between the races as a dominant pillar of science. So dominant, so useful to politics, to the dominant society, and to white supremacy, that it continues to be prominent to this day. Just to give another example of this idea of nature creating the races as a so-called moral excuse for slavery that Dr. King was talking about, Thomas Jefferson is a perfect example of naturalist, statesman who fancied himself to be a kind of scientist and observer of nature. And he also, as one of the drafters of the Declaration of Independence, which was based on Enlightenment principles of equality and tolerance and liberty, had to come up with a moral rationale as well. And he used the same idea that the reason why Black people could not be emancipated and certainly couldn't be part of this new democracy he and others were establishing was because of the real distinctions that nature had made. Now, an important aspect of promoting this idea of a natural division between races, a natural hierarchy of races that explained the political inequality of white supremacy was the concept that doctors came up with, that people of different races have different diseases and experience common diseases differently. Doctors were essential to promoting the lie, the myth, the falsehood that scientists were inventing of biological race, because they were seen as the experts on how human bodies functioned. And they were also seen as benevolent. And so it was easier, I think, for doctors to claim that the oppression of Black people was part of nature, that it just stemmed from natural differences between the bodies of Black people and white people, and also that this was actually good for Black people. Probably the most prominent of those doctors who articulated in the most detailed way this racial concept of disease was Dr. Samuel Cartwright, who practiced medicine after he was trained at University of Pennsylvania Medical School, which, by the way, trained many of the elite Southern doctors in the 1700s and 1800s, and also was responsible for the prominent ideas about biological racial difference and justifications for slavery. And Cartwright wrote a report on the diseases and peculiarities of the Negro race in 1851, where he identified as the main reason why Black people were better off enslaved, that Black people had lower lung capacity and had to be forced to work by white people in order to be healthy. And so he argued that it was good for Black people's health to be enslaved and bad for Black people's health to be in freedom. He came up with what he said was his diagnosis of a mental disorder that caused some Black people to flee plantations, which he called drapetomania, and diagnosed it as a mental illness for which the treatment was capture and corporal punishment. Now, this idea, the racial concept of disease, is taught at most medical schools today. And students are taught to immediately identify the race of patients and to interpret their symptoms according to race. And some of this is automatic. It's embedded in medical technologies. One really fascinating example is the spirometer, which Dr. Cartwright used to show the lack of lung capacity, the unequal lung capacity of Black people. And today, there are still some versions of the spirometer that automatically correct for racial differences in lung capacity. This is a term that is used to adjust for the race of the patient in measuring some bodily function, whether it's lungs or kidney function or brain function. I'm going to give you some examples of each of those. But the idea is that people of different races, that their bodies function differently. And so in any technology that measures whether the body's functioning properly or not, you have to adjust for race. To me, the clearest example of this is the measurement for kidney function, glomerular filtration rate. And the estimate for that is in most hospitals today, although many of us are advocating for a change, and we've succeeded in a handful of hospitals of getting this abolished, but still in most hospitals and clinics, there is an automatic adjustment for Black patients alone, as if Black patients' bodies, or kidneys anyway, function differently, or the measurement, what's used to determine proper functioning of the kidneys works differently in Black people's bodies. And so you can see in this example of the results of a routine lab test that if the patient is African American, it's adjusted upward, which means that it's seen as healthier. Recent research has shown that it disadvantages Black patients for referral to kidney specialists because they're more likely to be seen as having healthy kidneys, and also can disqualify them for being placed on a kidney transplant waiting list when a non-African American patient with the exact same measure would have qualified, again, because the Black patient's reading is automatically adjusted upward or to be healthier. Another example that's been in the news lately is the test for dementia that's being used by the National Football League to determine whether or not players who've sued for damages qualify for damages. And as of now, although players have sued to get rid of this, but Black players are given a different scale than all other players on the assumption that Black players' brains already were functioning less well than all other players' brains when they began playing football. And therefore, it's harder for Black players under this differential scale to qualify for a payout for damages to their brains. Another outcome of the white supremacist idea of biological differences between races and the justification for slavery was that African people were considered to be subjects for medical experimentation without their consent. Of course, during slavery, Black people were considered to be chattel property and to be legally incapable of giving consent. That just didn't compute because they did not have a legal right to object to what slaveholders wanted them to do. And so doctors like Marion Sims could conduct experiments on enslaved women without anesthesia and without seeking their permission. I could give lots of examples, but probably in more recent years, the best known is the US study of syphilis among Black people that looked to see whether there was a difference between the way that syphilis affected Black people's bodies and other people's bodies with about 600 Black men being tested for the impact of syphilis and going untreated, even at a time when there were treatments available. I'll just give one more example of the one type of harmful outcome of this idea that human beings are naturally divided into races, and that people of different races have bodies that function differently according to their race. And that is the undertreatment of Black patients for pain. A number of studies and just experiences reported by Black patients show that Black patients are less likely to get any pain medication, or likely to get less pain medication than white patients for the same injuries, like long bone fractures that are known to be painful. Another study found that Black children with appendicitis and severe pain in emergency rooms were less likely, far less likely to receive opioid pain treatment. And I've long suspected that the reason for this was because doctors and other healthcare professionals held stereotypes about Black people, that we experienced pain less, or that we exaggerated our pain, and that we were more prone to drug addiction than other people. And this connection between stereotypes about racial differences in how people's bodies work and the undertreatment of Black patients for pain was borne out in a study, 2016 study at University of Virginia Medical School, which found that a substantial number of white medical students and residents who were treating patients held false beliefs about biological differences between Blacks and whites. Beliefs like Black people have thicker skin than white people, and Black people have less sensitive nerve endings than white people. And they found that these beliefs predicted the undertreatment of Black patients, both first the differences in whether the medical student or resident thought that a Black patient was in pain, and then differences in the accuracy of treatment, with Black patients less likely to get accurate pain treatment. I want to add, though, that I think we actually don't know what is accurate pain treatment because it's been determined by race. I've been in discussions about whether or not doctors over-prescribe opioids or not. And there's a lot of confusion about what would be the right amount to prescribe, because doctors, it appears, were over-prescribing opioids, and that's been connected to the opioid crisis, over-prescribing them to white patients. And so because opioids and other pain medication have been prescribed by race, we really don't know what is the proper, accurate amount of pain medication to prescribe. And that's why I think that prescribing any therapy by race doesn't make it more accurate. It makes it less accurate, because race overcomes what would be a better indicator of the right amount of therapy. Now, when the map of the human genome was unveiled 20 years ago, we're celebrating the 20th anniversary this year, actually, of the full map of the human genome, but there was a draft that was presented unveiled at a White House ceremony in June 2000, and President Clinton announced, as did all the researchers involved, that it showed that race was not a genetic category. Clinton announced that human beings, regardless of race, are more than 99.9% the same. And I think that he would have, should have pointed out that that 0.1% includes a lot of genetic variation, but it's not grouped by race. Again, race is an invented political category, so it could not be determined by genes. And we know that there are no big, clear divisions between human beings when it comes to genetics. So I, like many people, thought, oh, maybe we're going to now enter a new age where genetic researchers and biomedical researchers actually do a better job of understanding human biology and health inequities by stopping this practice of treating race as if it were a biological category. But in fact, there was a resurgence of interest in race-based genetic difference following the publication of the human genome and the larger databases and techniques, genetic methodologies that came out afterward. And I wrote a book called Fatal Invention: How Science, Politics, and Big Business Recreate Race in the 21st Century, documenting this renewed interest in genetic differences between races and the political implications of it. And so I argued in that book that scientists were providing genetic explanations for racial inequities that were supposed to have been ended in a supposedly post-racial society. I wrote this book when Barack Obama was president, and maybe people were a little more hopeful about it. It's interesting that whether we're in a post-racial society where you've got to come up with some explanation for continuing, even deepening racial inequities, if we're post-racial, or whether we're in a society like today where you have white nationalists storming the Capitol, the biological concept of race continues to be perpetuated. And also, not only on white supremacist websites, but as I've been pointing out, broadly in science and medicine, and also in the development of biotechnologies and pharmaceutical products. Ironically, when we're supposed to be in an age of personalized medicine, these big, crude racial categories continue to dominate. So I just want to give some examples of this idea of genetic differences between races as explanations for health inequities. One of the most serious and alarming health inequities in the United States is the difference in death from pregnancy-related causes or maternal mortality deaths between Black women and white women in the US. And let me just pause to say that most of my research has been about Black people in America, and so I'm emphasizing that. There are also disparities of various kinds in health and in income and incarceration between white people and Indigenous people or Native Americans, Latinx people, and in some cases, Asian American people as well. But my work focuses on Black Americans. So what causes these alarming differences? Well, differences in pregnancy-related outcomes for Black women and also for Black children with high rates of infant mortality in the Black community as well. And I just want to give an example of the continuing research that's looking for some innate problem in Black people's bodies to explain these differences. This was a study that was trying to explain why Black women have higher rates of premature birth. And the hypothesis was that Black race, independent of other factors, increases the risk of extreme preterm birth and its frequency of recurrence. And just think about this hypothesis that there's something that we could identify as Black race that can be separated from all social determinants of health, all aspects of structural racism that could have an impact on preterm birth. Every aspect of that is ludicrous and impossible, and yet it was a hypothesis that was presumably tested and published in a leading medical journal. Let me move on to an example of technologies using this concept of genetic difference in the races, and that is the first race-specific medicine that was approved by the Food and Drug Administration, a therapy for heart failure called Bidil, which the FDA allowed to be labeled specifically for African-American patients. And I don't have time now to go into all the details about it. I'll just say that this drug was developed without regard to race. Its first patent didn't mention race, and it was repatented for commercial reasons. But for now, I want to emphasize how it was that the FDA could justify labeling a drug just for Black people. And the chair of the advisory committee stated that they were using self-identified race as a surrogate for genetic markers. This was before any genetic markers were found to be relevant to either the heart failure or the efficacy and safety of this drug, and without any evidence that Black people had some genetic markers that distinguished them from other people suffering from heart failure. But there's this assumption of genetic differences between the races that can just be rolled out without any support whatsoever, and can even be the basis for the action of the Food and Drug Administration. So let me return to Dr. King to think about what would be a better approach. And Dr. King pointed out that even though we've made lots of advances in science and technology, there's something missing. He called it a sort of poverty of the spirit. I might call it a poverty of justice, which stands in glaring contrast to our scientific and technological abundance. One of his great quotes, it doesn't get quoted enough, I think, is "We have learned to fly the air like birds and swim the sea like fish, but we have not learned the simple art of living together as brothers and sisters and other family members." So King was pointing out that there can be great scientific and medical advances, but they don't necessarily promote justice. In fact, they might go counter to justice. And let me give you an example of that. In 2006, there was a study published that showed that Black women in Chicago died from breast cancer at twice the rate of white women, even though they got breast cancer at the same rate. And again, some people might jump to the conclusion, well, there must be something that predisposes Black women to death from breast cancer that is in Black women's bodies, but not in white women's bodies. But what they found out was that in 1980, Black and white women died from breast cancer at exactly the same rate. And what happened was that over the next 20 years, there emerged this huge gap in deaths. Actually, what happened was not that Black women's death rate increased, but that white women's survival rate doubled. And the researchers believed that it was because over those 20 years, there were huge advances in breast cancer detection and therapy, and Black women in Chicago got absolutely no benefit from it. Now, there has been a long-standing resistance to the idea that human beings are naturally divided into races, that the races are biologically distinct, and that this is what explains continued social inequities in health. For another lecture, I could talk about explanations for inequities in poverty, in incarceration rates, in education, and these theories continue to dominate science today. But just still focusing on health, W.E.B. Du Bois, 100 years ago, made the point that the reason why Black people in Philadelphia had higher rates of consumption wasn't because there was something innately peculiar about them, but because of living conditions, unequal living conditions in Philadelphia. And he tied this to a political point by saying that the Irish were thought to be doomed by consumption as well because of some innate defect in their bodies, but that was when Irishmen were unpopular. Pointing out that these biological theories to explain social inequities happen to people who are oppressed, and their oppression is explained away as the result of biological difference. Today, there are more and more researchers, many of them sociologists, sometimes teams of sociologists and biological researchers who are looking at the way in which social inequality, in particular structural racism, gets embodied or gets under the skin in order to produce these unequal outcomes. One of those studies actually looked at levels of structural racism and tied their measure of structural racism to rates of heart attacks among Black people. Another set of studies have looked at how police violence affects public health, both the health of Black Americans in general because of the impact of police killings on unarmed Black Americans on all of us, but also looking at the impact of health in communities, on the residents of communities where there's a lot of use of force or surveillance by police officers. In Fatal Invention, I sum it up by talking about how racism gets embodied. So race is not a biological category that naturally produces health disparities because of genetic differences. It's a political category. I'd like to say a political invention that has staggering biological consequences because of the impact of social inequality on people's health. And I think that the research and the thinking around how to understand the impact of structural racism on health and how to treat it is very important. I do caution that we keep our eye on the structural inequities that need to be changed, that it's not just enough to intervene on the biological outcomes. We're not going to solve these problems if we don't end the structural racism. I will close with another quote from Dr. King. and I should have mentioned the other quote was not from his book of sermons, Strength to Love, but was from his Nobel Peace Prize acceptance speech, as is this one where he said, "There's no deficit in human resources. The deficit is in human will." And there are lots of ways that medical students especially are coming up with how to practice medicine and study the human body in a way that it puts justice at the center. One idea is structural competency for medical students that asserts that medical students should be competent in how social structures affect patients' health. And there's lots of innovative work going on how you would actually implement that in the clinic and advocate for it outside the clinic in terms of social change. So I will just close with the point that the best evidence, I think, is that a more equal and just society would be a healthier one. And that ultimately is what we need to strive for to end the health inequities that we continue to see in America today. Thank you.
Hi, Dorothy, thank you so much for that. That was wonderful. I want to, and I hear some people, there's some people saying in the questions that they want to clap. So there's a lot of silent clapping for you, Dorothy. My name is Adrienne Davis, and I'm a Vice Provost and William and Van Cleve Professor and Co-Director of the University Center for the Study of Race, Ethnicity, and Equity. If you have questions, please put them into the question answer. If you look along the bottom of your Zoom screen, just immediately to the left of chat, you'll see Q&A, and if you put your questions in there, I will read them to Professor Roberts. I want to say how excited I am to moderate today, because Dorothy was one of the reasons that I became a law professor. Her work showed us how crucial it was for legal scholars to help understand how law contributed to racial supremacy and to help us imagine ways to disrupt it. So I really want to thank Dorothy for all the work that she has done.
Thank you. Can I just say it's so good to be on this program with you, Adrienne, and you're one of those people who, I used to be your mentor, and now you have just surpassed me in glory.
Oh, no. You're still my mentor, Dorothy. Once a mentor, always a mentor.
Okay.
You're not letting you go. I have a quick question for you, and then I'm going to ask a question from our dean, the dean of the medical school. So my question is, I just loved everything you said, and I think you broke this down to us in such important ways. And I just tweeted I think that one of the last things you said, that race is real, but it's a political category. It's not a biological category. Mm-hmm. So I know that you're not calling for colorblindness, right? I know that. So can you just tell us a little bit about, we know that you've given us just a great, horrible, but a very, very thick and incisive roadmap of the history and the ongoing ways that race generates health inequity. What is the right way to think about race in this context to try to drive health equity?
Yeah. Well, I'm glad you asked that question, because there are a lot of people who, when you say take the biological concept of race out of biomedical research, out of genetic research, out of medical practice, many people do interpret it as you're saying, be colorblind, don't pay attention to race. And I'm not saying that at all. I'm saying have the right understanding of what race is. Race is real, like you said, you just tweeted, right? It is a real category. It is a real political classification system that is really used to govern people, that really has a huge impact on every aspect of our lives. I mean, it has an impact on the system of race, right? The classification system. But it's not the biological differences that are having that impact. So one way of thinking about it is to understand that it is racism that is having that impact. And one of the sayings that's, I think, very useful is that racism, not race, is the risk factor. It's racism that's causing. Now, of course, race is connected to racism in lots of ways. It's, to me, race was invented in order to implement racism. If you're going to be racist, you have to have you have to categorize people. You have to have a system that says this is how we identify who's Black, who's white, who's Native American, who's Asian American, and here's what that means for people. It has a meaning in our society, and that's what we have to understand. So that's why I found it very useful to say race was invented, and it is invented. It's reinvented all the time, because I found that people, when you said, say it's a social construct, they still think, well, it's a biological category that we socially construct. But no, the very idea that human beings are divided into races is an invented idea to begin with. And, so just keeping in mind that it is racism that has the impact on us, and race is an invented category to manage, to manage racism. Now, that also doesn't mean that we can't have our own ways of identifying, that it doesn't have certain cultural aspects to it as well, that people who are identified as belonging to different racialized populations have invented for themselves as well. But it's still all invented.
Thank you, Dorothy.
Sure.
Thank you. I'm going to read a question from our dean, the dean of the School of Medicine, Dr. David Perlmutter, and I think it's in two parts. I think I see two pieces to it. First, he wrote, would you comment on evidence that trauma affects genetic susceptibility to disease?
Okay.
And then I think that there's a follow-up where he elaborates, this seems to work through epigenetic changes and can be passed on through generations. I mean, environmental trauma, including pollution, poor living conditions.
Yeah. Okay. So I believe the dean is referring to epigenetics, which is the way in which the environment, which can be the social environment or the physical environment, affects the expression of genes. And so one easy example to understand is a pregnant person who is living in a stressful environment or has poor nutrition. That can affect the fetus. It doesn't change the genes of the fetus, but it can affect the expression of genes. And that can be carried on through that now born child's life into adulthood and have an impact on that adult's life. Again, not because their genes were changed, but because of the expression of genes affected by the in utero environment. Now, another example is the way in which trauma, as the dean mentioned, which produces stress, can have an impact on the expression of genes. This doesn't all happen through, pregnant women. This also could just happen directly on somebody and the way in which their genes are expressed. Which might explain, for example, why you could have identical twins who have different health outcomes. Epigenetics isn't the only pathway, but I think it's useful because it points out that we're not talking about the inheritance of genes that operate to produce health outcomes. We're talking about the operation of the environment on gene expression. And that in a way can be more hopeful, because then if you change the environment, you can change the gene expression and avoid the deleterious outcomes that come from it. Now, having said that, I made a little aside when I was giving my lecture about focusing on the structural inequalities and not just on the biology, because one thing I found some people studying epigenetics is they get so involved in the biological mechanism of epigenetics that they lose sight of the social environment that caused the problem. And so their solution is, oh, we must intervene, in pregnant women's bodies, or we must intervene, in the epigenome. When actually what this should be telling us is that social environments can produce harmful outcomes, and that's what we should be focused on. So I do get concerned when there's so much emphasis on the biological mechanism. It almost becomes like a genetic structure, because the what's causing it gets obscured. And let me make one other comment about the idea that it's inherited. It's not inherited like genes are inherited. They're not, the epigenome, as far as we know, there's no evidence that the epigenome is passed on. So that, that fetus whose genetic expression was affected, who then becomes an adult with heart disease because of it, they're not going to pass that on to their children unless they also are living in that continued environment. But it's the environment that's passing it on. It's simply speculation at this point that epigenomes themselves are inherited like genes are inherited. And I think this is important, because if we believe that epigenetic mechanisms are self-perpetuating and inherited, then we're back where we started with biological determinism. What can you do? There's no way to intervene other than in the epigenome itself, because that original trauma caused by social inequality, it's seen as being passed on generation after generation, regardless of how we change society. And that's, I think it's really important to understand that, for example, the enslavement of African people, that's not a trauma that's inside Black people's bodies that's passed on. What's passed on are the structural aspects of white supremacy and racism that continue and have effects, including epigenetic effects. So I think this is a really interesting and important area, this biosocial area that sees that social inequality has biological effects, but it's not any less complicated than any other aspect of science and race, and inequality. It requires critical attention and innovative research models and solutions. Otherwise, we're back at Black people's bodies are defective, and that's why they're in such bad shape in America.
Thank you, Dorothy. And also, I was remiss in not thanking Dean Perlmutter and my colleagues, Dr. Will Ross and Dr. Cherie Wilson, and the entire committee at the medical school for the entire, not just this event, which is extraordinary, but their entire week of Dr. Martin Luther King commemorative events. The medical school always does just a tremendous job. So I encourage people, maybe someone can put into something that everyone can see, just your list of events for the week, because it's really exceptional. I want to read a question from Rachel Lee. She's, and also you can't see it, but you have lots and lots of plaudits and people saying amen and you're brilliant and that was wonderful. So lots and lots of that, lots of beaming faces, virtual faces here. Rachel Lee writes, your book, Fatal Invention, was remarkable, exclamation point. Our book club, which was nurses around the country and one media professional, have been studying it and talking about how we can make changes at our institutions I'm sorry, I just lost the last part of that. This is the, hang on one second. I will get back to the bottom of the chat again. Hang on. Here it is. Can you speak about why you think Black political leaders bought into and supported Bill Dill? And maybe you can tell the rest of us who Bill Dill is.
Yeah, interesting question. So that's the therapy for heart failure that the FDA approved specifically for Black patients or African American patients. One of the confusions that these categories always have, that I mentioned in my lecture. And as I mentioned, it was developed by a cardiologist to treat any patient with heart failure. It simply is the combination of two generic drugs that have been marketed for a couple decades prior into one pill that dilates the blood vessels, and so makes it easier for the heart to pump blood. And I think, so just to add a little bit to Rachel's question, for those who aren't as familiar, there were a number of Black organizations, including the NAACP, that supported it. The Black cardiologists were in charge of the clinical trial, which only included African Americans to test it. And there were members of the Black Congressional Caucus who supported it as well. So I think there are a number of reasons. One is that there was a sense, which continues today, that there hasn't been enough funding and attention paid to the greater burden of many diseases on Black people and Black communities, and that this was an example of the federal government focusing on Black people's health, which is good to pay more attention to Black people's health, but this was a commercial product that was being approved for marketing at a very high price. This was not a government effort to address health inequities and to think broadly about why is it that Black people get heart failure at younger ages. Why is it that there is this greater burden of death, and how can we get at the root causes for that? So I understand that motivation, but I don't think that BiDil is the kind of answer to addressing the greater burden of many diseases that Black people have. The other thing is that there was money in it for some people. I won't name names. I don't want to cause any more controversy, but people had contracts from the Nitramed, the corporation that marketed it, millions of dollars. Some Black people got to market in Black communities this drug. And so there was a financial incentive. I think there was also involvement of Black people in the development of BiDil and the testing of BiDil who may not have agreed with it being labeled just for Black patients. So, you could be involved, a cardiologist involved in the huge, for Black people, huge clinical trial to test the efficacy and safety of BiDil without thinking that it needed to be marketed just to Black people. I mean, most drugs on the US market today were tested on white people. And there isn't anybody saying, oh, well, that means they only work in white people. Well, I shouldn't say there isn't anybody, but the FDA isn't saying that. So it's possible to have approached it a different way, to just simply test the efficacy of it. If there's, there could be a clinical trial with African Americans, but that doesn't mean that it has to leap to the conclusion that it works in African Americans because of some biological distinctiveness of African Americans. To me, that sends the message that a drug that works on Black people may not work on other human beings because Black people's bodies are so peculiar. And that's not the message that the FDA has sent when it comes to other drugs or other groups of people. And so while I could understand the idea that, okay, Black people have been excluded from clinical trials. Black people have not had the attention that other groups have had when it comes to dealing with therapies and other ways of addressing health inequities. But developing and marketing a pharmaceutical for profit that based on a message that Black people's bodies are biologically distinct without any basis for that, that's not the way to do it.
Thank you, Dorothy. I am going to combine what I think are a really nice set of questions, hopefully into one question, including from my my colleague, Dr. Diana Gray. And I'm just going to kind of lift a couple of things out, but really it all comes down to the question about how do we change this? Diana says, I think the concept of race as a socio-political construct rather than a biological construct is key to erasing healthcare inequities. How do we embed this into all of our discourse around healthcare and education? Another person asks, how might the education of medical professionals be changed to root out the assumption of medical differences on the basis of race? Someone else, an African-American psychiatrist, said that they've been working on this, trying to teach counter to this, doing counter teaching for the last 30 years. How can we make this official? Are there any key foundational concepts to learning, unlearning how to be an anti-racist physician? So I'll pose that all of those to you as kind of a set.
Yeah. What do we do about this, especially in medical education? So first, I want to say, I think that medical education is a key place to address this. And because, for hundreds of years, these ideas have been promoted and passed down from clinical professor to, physician, to trainee, resident, medical student. And I've had so many medical students say to me, I understood that race was a socio-political construct before I went to medical school. And then, in order to succeed, I had to stop thinking that way. I was taught that it's a biological concept and that I must look for biological differences between the races. And that's the only way I can practice medicine. And that's the only way I can pass my tests, and please my professors. So that is, I think, critical to change the medical curriculum. And students are out front demanding these changes. The reading group that was mentioned, I don't know if it's the same one, but I know that University of Washington put together a curriculum that included my book, Fatal Invention, and has been promoting changes in medical curriculum. At Penn, students are working on changes. They've identified various ways that the biological concept of race is taught in a number of courses and recommended changes. And there's others. Brown Medical School has as well as many others. So I think students working with faculty and clinicians and administrators is a really powerful way of making these changes. And I think the to do it concretely, to point out examples from courses where this false concept is being taught, to recommend alternatives, recommend alternative readings, meet in reading groups, recommend courses. It takes organizing and a lot of effort. It's not easy to make these changes in ideas that have been embedded for hundreds of years. But I have seen in this past year more changes than I've seen in the 30 years prior that I've been looking at this issue. So there's a lot happening. The other is to make concrete changes in medical technologies that embed these ideas. And one is, I mentioned the EGFR for kidney function. And I also mentioned that there are now maybe 5 or 6 hospitals just in the last year that have ended the race correction as a result of organizing by students and faculty and clinicians and administrators. It's an example of how organizing for change can have a concrete impact. I think as we get rid of race correction, which automatically and categorically assumes that a patient's body operates differently just because of their race. It's so stark. I think that it can be a path toward making other changes. I'll just mention one other. I think I mentioned it briefly in my lecture, and that's the concept of structural competency, that medical students should be structurally competent. They should understand the social structures, including structural racism and economic inequality, other kinds of systemic inequalities that affect patients' health. And it's seen as a substitute or modification, maybe. It depends on how cultural competency is taught, and understanding that sometimes cultural competency teaches students stereotypes about people of different cultures and leaves out how structures affect health. And so there is more and more work being done on how to not only theorize structural competency, but put it into practice. And I would recommend work by Helena Hansen and Jonathan Mossell on this. I believe there's an edited volume that Helena Hansen, I think it's out. I know I wrote the foreword for it, but I haven't gotten my copy of it yet. But I think there's an edited volume where doctors who are practicing cultural competency give concrete examples of how to do it. And so that's another area where I've seen a lot of innovation and change.
Dorothy, quick question. Do
Sure.
you think that a patient's race should be collected as part of the clinical interview and documentation?
Well, I always think it depends on why. The problem now is that it's so connected to all sorts of assumptions, biological categorical assumptions made about patients, that I'm tempted to say it should not. And that's because it has been tied to a biological concept of race. And so I don't want to say it has no place at all in medical practice, but at this point, it's used in such a confusing and harmful way that it might make sense. And I don't at all want to say that I have an absolute answer to this. I think that this needs a lot of work and innovation, but I have found that sometimes you have to force people to imagine, okay, how would I do this if I didn't rely on race? This is what we're doing with the EGFR. once you get rid of race correction, you have to figure out, okay, what's the best way to measure kidney function? Like I said, with pain treatment. Okay, if we're not going to assume that Black people shouldn't get opioids because they're predisposed to drug addiction, and we'll assume that you can prescribe lots to white people because they're immune from drug addiction, if we get rid of those stereotypes, now what do we do? Same thing with EGFR. Race has been categorically relied on, and that has been an impediment to coming up with a better measure. So once we abolish it, get rid of race, now we can figure out what's a better measure of kidney function. And so I don't want to give an absolute edict on this, but I think that if we get rid of putting down the patient's race, why do we put it down? Because it's supposed to affect the diagnosis and treatment of the patient. So if we don't, and doctors are forced to think about, okay, what are the indicators that I was using race for? Because race is a proxy for something more important. So what are those more important indicators that I want to ask the patient about? Maybe it'll take more time now to interview the patient to get at what I was using race for. But I think that at this point, it looks to me like that would be better. Now, if to the extent that race is important to understanding how racism has affected someone's life and health, then it could be useful. But that's not the way it's used now. So, this is a dynamic process,
It's a dynamic
I think.
process. It seemed, thinking about, you talked about just these really appalling statistics about Black women's maternal morbidity in infants, which is something that it's, class does not adjust for the way that it typically does for white women. And so it is intriguing to think about whether the questions might become something, an open-ended question to patients, which would be something on the order of, are there ways that you believe your identity generates stress, or that you feel like you are affected by structural things, and let the patient tell you.
Good idea.
Those decisions, right?
Exactly. Because clearly race and racism intersect with other identities. And for some people, those other identities might have a greater impact on their health, or they may intersect in ways clearly that are different for one patient than another. The maternal mortality, for example, is really high in the Mississippi Delta among Black women living in the Mississippi Delta. Well, the conditions of those women, the other aspects of their identities, very different than, when I was pregnant as a university professor in Chicago, or New York City, or as a high-paid lawyer at a big Manhattan firm. There, my stresses were different, but if I were to talk about that, I might point out the stresses of being a lawyer, and so I think that's a really good point, Adrian, that it's let the patient tell you what are the aspects of the patient's identity that are affecting the patient's health. I think a lot of the reliance on race is connected to the little time that doctors have to talk with their patients. And so it may be easier to just say, oh, okay, Black female, age 64, we'll just make all sorts of assumptions about that, rather than actually have a discussion with the patient that's open-ended the way you suggested.
And develop okay, I've got a lot of questions to get through. Let me see. This next one I think is really intriguing.
I think Dr. Ross is.
So I was just saying that we have 10 minutes, and so we'll have to try to condense all these questions in this last 10 minutes.
Okay. So calling out race and racism as the cause of these disparities is important to push back against assimilationist rhetoric that tells people of color that we need to become more white. But this is difficult in medicine, since so many ideas of health that have been set are explicitly white, cis, het, Christian conceptions of normal,
Yes.
rather than true descriptions of optimal functioning and living.
Yes.
What are ways that you have found to effectively push back against these ideas in medicine, which is so focused on outcomes?
Yeah, yeah.
Not a great question.
It is a great question. And it also points out that there are problems both ways, both the idea that people of different races have these peculiar aspects of their bodies, and their personalities that affect their health in distinctive ways. That's one problem. Another is the assumption that the white heterosexual male, is the standard of what a human being should be. And so I'll give an example of that. I have been speaking out a lot against the automatic adjustment in the EGFR for Black patients. There was an article the other day that pointed out that the oximeter, I think it's called, that test for oxygen level, which has been so important during the COVID pandemic, is less accurate for, now it came out for Black people, but what it actually is the color of the skin, because it uses light, and the skin color or whatever it's going through makes a difference. So, but why is that? Because it was calibrated for light skin. And there's an example where it's because of a white standard as what human beings are that ends up disadvantaging Black people. So, with the EGFR, it's a focus on Black people as being distinctive and adjusting for Black race. With the oximeter, it's focus on white people as the standard and ignoring people with darker skin. Both are wrong, right? Both are problematic, and we have to address both of them by ending both these assumed biological categories, but also the hierarchy within them that sets up whiteness as the standard for humanity. I think that the effort to be more structurally competent, to get rid of categorical thinking, helps to be more complex in the ways in which we think about human beings, more attentive to the various identities that people have and the different ways that they intersect, more attentive to the great genetic diversity in human beings, while also understanding our commonalities. I'm going to try, I'm not sure if I'm being specific enough to answer the question, but broadly speaking, this deterministic categorical thinking that has so dominated medicine and science more broadly, Western science, is extremely harmful. And again, I think it's rooted in ways we really haven't thought enough about, to the justification for slavery and dispossession of indigenous people, and which required putting people in these categories and making assumptions, categorical assumptions about human bodies. And we need to abolish that way of thinking. And I think that question points out the complexity of what it means to abolish that thinking. And I'll leave it at that. I'm sorry if I didn't give enough of a concrete example, but sometimes it's also important to have sort of, big ideas about how to go forward, because really we don't have enough yet of concrete examples, right?
No, you did a great job, and I think the going back and forth between the very technical and the big vision is perfect. Let me see if I can get in two very quick questions. They're not quick, but you can get they're big questions, but you can see if you can give.
I'll try.
Just a sense of how you might think about them. So I think this is my colleague, Dr. Alex Carter. It's Alex Carter. I think it's Dr. Alex Carter, who's my colleague, who puts insurance on the table. Says that minorities are disproportionately represented on Medicaid enrollment, for instance. Can you comment on how we might approach this inequity as, academics, medical doctors, nurses, et cetera? And then if you have a moment, someone says, just this talk, your talk is brilliant. Given the crucial way that social and structural forces dictate health outcomes, why do you think insights from social medicine remain marginalized?
Yeah. Well, so let me, big answers to those questions. So the first one, I would say that there is, in US social welfare policy in general, whether we're talking about public assistance, so-called food stamps, welfare, Medicaid, there has been a long history of linking public assistance to racist ideas about Black people in particular that stigmatizes these programs, and lots of examples of how Medicaid gets stigmatized because of its association with Black people, that led to the abolition of the guarantee to public assistance for parents. I think on the one hand, one way of addressing it is that we need more universal programs like either Medicare for all, or more broadly, a single payer universal health care for everybody. I would also say, though, that we also know that universal systems, they mitigate racism, but they don't eliminate it. And so we have to, at the same time that we advocate for universal healthcare and other kinds of state support for human needs, that we work to eliminate what we've been talking about today, the ways in which racist ideology is so embedded in so many aspects of our lives, and will continue to be embedded even after universal programs are in place. We need both. As I pointed out with Du Bois, there's a long history of understanding that social inequality affects health, but it has been marginalized. It's been marginalized in funding. It's been marginalized in newspaper headlines. It's been marginalized in the prestige, of research and professions. And it gets marginalized because the biological concepts of innate determinism, have been such a powerful way of supporting the status quo. They're just such compelling justifications for why we have inequality. Whether we're talking about, as I pointed out, the justifications for slavery during the Enlightenment, or eugenics, eugenics is all about justifying social inequality through biological deterministic ideas. And those deterministic ideas, which are still so popular today, the idea that educational attainment is caused by genes. There's articles being published all the time today that are perpetuating this idea, and that genetic testing is the answer, to educational inequality. They continue to be popular, And I think they're popular because they support the status quo. They do not support social change. The people who would be benefited the most from social change are the least likely to be prominent in discussions about the ethics, or the technologies, or where the funding is going to go. And we haven't talked a lot, but let me put in a plug for this as well. Bringing in community voices. Okay, it's more important. Let me just say, very, very hopeful that Alondra Nelson is the deputy in this new Biden and Harris cabinet level position of science and technology. And so I'm hopeful that we can see some change in this area that the questioner was asking about.
Well, thank you, Professor Roberts. Just remarkable, absolutely remarkable presentation.
Yeah.
Thank you, Vice Provost Adrian Davis, for really shepherding these really complex questions, condensing them, and really putting them to Professor Roberts in a way that was really manageable and bite-sized. So we really thank you, Professor Davis, for your expertise. Professor Roberts, this has been outstanding. I stand in support of the Dean and the Chancellor, the entire Washington University community, as well as the entire St. Louis community, who actually have just thoroughly enjoyed and been enlightened by this presentation. We will act on a lot of this. We need to move forward, and I assure you that this is going to be embraced by so many who are really moving for change. There are a lot of questions that were not answered. To those, I was in our regrets. We couldn't get through everything, but I clearly know that Professor Roberts is going to be in her position back at Penn, putting a lot of posts online, hopefully addressing some of these questions. Professor Roberts, I want to also extend an invitation. Our own Department of Genetics, which has been on the forefront of really discussing the ethics in the same way that you've mentioned. Would love to have you contact them, Dr. Brett, Marika, and others. I'll give you that connection because there's so much to do here with our own Department of Genetics, and we really applaud you for wanting to step out and do all this great work. And so there are so many hands shaking, in the air because we can't give you a standing ovation, but I want you to know that you have been very well received and well respected. To the audience, thank you for coming and participating in our MLK celebration. We hope to see you back next year in a full in-person format. And I hope to see you later this year as we continue to give these presentations to you, the greater community. Thank you all. Please enjoy the rest of your day and please sign on to more of our MLK celebration activities this week. Thank you. Thank you, Professor Roberts.
Thank you.
Love you. Love you to death. Have a wonderful week and a wonderful month.
Thank you so much.